classes by MMDS, and our topic of discussion today is dental bleaching. In our previous video, we have already discussed the causes of tooth discoloration. So herein in this chart, we summarize the same causes. In this, the causes are divided into the patient-related causes and the dentist-related causes. Under the patient-related causes, we have pulp necrosis, which is also one of the most common cause of tooth discoloration. Then we have intrapulpal hemorrhage that usually results because of the trauma to the tooth. We have dentine discoloration. We have dentine hypercalcification. Dentine hypercalcification results because of excessive deposition of dentine, and this excessive deposition of dentine shows through the enamel layer, and it gives a yellowish discoloration to the tooth. Then we have aging. Aging may result in discoloration due to various reasons such as the extrinsic staining. It can be because of excessive dentine deposition, further the loss of the translucency of enamel, and there are roughness, pitting, adhesion, roughness of the tooth that attracts more of stains. Then we have some tooth formation defects, that is a developmental defects such as amelogenesis imperfecta, dentinogenesis imperfecta, etc. We have some drug related staining, in that we have some drugs that result in extrinsic staining such as chlorhexidine and minocycline, while we have some other drugs which cause the intrinsic staining such as tetracycline. We have seen all these drugs and the details in our previous video. Under the dentist related causes, we have the endodontically related causes, wherein if the dentist leaves behind the pulp tissue remnants because of the improper debridement, this remnant may disintegrate and result in discoloration. Some of the intracanal medicament which are used in the pulp canal may cause discoloration of the tooth. Some obturating material may result in discoloration of the tooth, and then we have some restoration related discoloration, in that we have amalgams, pins and posts, and other metallic restoration that may cause discoloration. Then we have composites which are very prone to abrasion, erosion, and the discoloration because of the extrinsic agents. So this is just the summary of the cause of the tooth discoloration, and as we have already saw, the decomposition of pulp is the most common cause of tooth discoloration, and particularly if the pulp has become necrotic. While if there is hemorrhage in the pulp, this hemorrhage results in breakdown of hemoglobin that forms the products such as hemin, hematin, hematoidin, hematoporphyrin, hemosiderin, etc. And these products are responsible for tooth discoloration. Other than that, some of the bacteria produce hydrogen sulfide, and this hydrogen sulfide can combine with hemoglobin to darken the tooth. And this is an important MCQ, and this is an important MCQ. So this was a brief recap of the causes of the tooth discoloration. With this, we'll move on to bleaching. And before we go into the bleaching proper, let's look at the conditions which are easy to bleach out and the conditions which are not so amenable to bleaching. So the conditions which are comparatively easy to bleach, in that we have the discoloration because of pulp necrosis, which is also the very common cause of discoloration. Further, with the extrinsic stainings, most of the extrinsic stains and the stains because of hemorrhage, etc., are easy to bleach out. Further, the conditions which usually have resulted in discoloration during the developmental phases, they have some deep-seated stains and they are difficult to bleach out, in that we have erythroblastosis fetalis, high fever during tooth formation, porphyria, we have amelogenesis imperfecta, dentinogenesis imperfecta. So these are the conditions which happen during the developmental phases, and they are comparatively difficult to bleach out. Most of them are the intrinsic conditions, while there are some extrinsic discoloration like silver nitrate stains, which are almost impossible to eliminate because they penetrate the surface of the crown. Since they penetrate the surface of the crown, they're not easy to remove only by the chemical means, and we may have to resort to grinding to remove these stains. Now this is an MCQ that silver nitrate are difficult or not amenable to bleaching. Further, we may have MCQ on these conditions as well. Next, we'll be talking about the bleaching agents which are used in the process of bleaching. In that, the most common and the most important one is superoxole. Superoxole is 30% solution of hydrogen peroxide by weight. Now, this point that by weight is important. So when we consider it by weight, it is 30% solution of hydrogen peroxide in distilled water. But if we consider it by volume, it is 100% by volume in distilled water. Now both these are MCQs. Now if you talk about the properties of hydrogen peroxide, it is an odorless substance, it is unstable in heat, so it has to be kept refrigerated in containers, and they retain the potency for approximately 3 to 4 months. It is a very caustic chemical and it may result in chemical burns. The next agent which we'll talk about is sodium perborate. Sodium perborate, it is stable. Now we have seen that H2O2 was unstable, but sodium perborate is stable. It is available as white powder and normally it is supplied in the granular form, and when we are using it, it has to be ground into powder form. And the powder of sodium perborate, it is water soluble, and when it is mixed in water, it decomposes into sodium metaborate and hydrogen peroxide, releasing oxygen. And if you talk about the pH, it is alkaline in nature. So sodium perborate itself is not the active ingredient. When sodium perborate is mixed with water, it releases sodium metaborate, H2O2, and then it releases oxygen, which is responsible for bleaching. When sodium perborate is mixed into a paste with superoxole, this paste decomposes into sodium metaborate, water and oxygen. And this paste, this mixture of sodium perborate with superoxole is called as walking bleach. We'll be talking about it in the later slides. Now see the difference here. And when sodium perborate was mixed with water, it had released sodium metaborate, H2O2 and oxygen, while when sodium perborate was mixed with H2O2, it is no more releasing H2O2 but rather it is releasing H2O. So herein it releases sodium metaborate, water and oxygen. So important point to be noted and the source of MCQ. A third agent is carbamide peroxide, and it is also called as urea hydrogen peroxide. It is available in the concentration range of 3 to 45%. Now, most of the commercial preparation of carbamide peroxide, that is the urea hydrogen peroxide, contains approximately 10% of carbamide peroxide with a mean pH of 5 to 6.5. Now we can have MCQ here, we can have MCQ on the common percentage of carbamide peroxide, and we do have MCQ on its name. Now solution of 10% carbamide peroxide break down into urea, ammonia, carbon dioxide, and it releases 3.5% of hydrogen peroxide, which is the actual bleaching agent. The percentage is again important MCQ. So carbamide peroxide, which is nothing but urea hydrogen peroxide, releases 3.5% hydrogen peroxide to bring about the bleaching effect. Now bleaching preparations containing carbamide peroxide usually include glycerin, propylene glycol, sodium stannate, phosphoric or citric acid, and flavor additives. So basically these are the supporting agents wherein these propylene glycol, glycerin, etc. are the vehicles. In that, carbopol, which is a water soluble polyacrylic acid polymer, it is added as thickening agent. Now, carbopol is nothing but polyacrylic acid polymer, and it is the thickening agent added in the compositions of carbamide peroxide. Carbopol also prolongs the release of peroxide, so it increases the life, the bleaching effect, and it does improve the shelf life of urea hydrogen peroxide, that is nothing but carbamide peroxide. The carbamide peroxide is an agent that is used for night guard vital bleaching, and this point is an important MCQ. Next, we'll be talking about walking bleach. So just now we have discussed the three main bleaching agents, that is hydrogen peroxide, sodium perborate, and carbamide peroxide. Next, we'll be talking about the walking bleach. Now, the superoxole, that is nothing but 30% hydrogen peroxide by weight. It can be used alone, or it can be mixed with sodium perborate into a paste that is called as walking bleach. Now, when superoxole is mixed with sodium perborate decomposes into sodium metaborate plus water plus oxygen. And this walking bleach can be sealed in the pulp chamber. It oxidizes and discolors the stains slowly. So it can be left inside the pulp chamber, and patient can go home with the bleach inside the pulp chamber, and this bleach is effective for a longer period of time, slowly bleaching the tooth. Hence it is called as the walking bleach. Now there are a lot many MCQs on walking bleach, including its composition, including its use, etc. Now, how is the walking bleach placed in the tooth? So herein we see the steps in the placement of the walking bleach. The first step is prophylaxis and polishing of the tooth. After the prophylaxis, petroleum jelly is applied to the gingival tissues to protect them from the caustic effect of the bleaching agent. After that, we adapt the rubber dam for isolation. Then the access cavity is re-established. Now it's very obvious, since we are placing this particular walking bleach inside the tooth, obviously the tooth is non-vital and it already has the access cavity and root canal filling done. So in our fourth step, what we are doing is we are opening up the access cavity again so that we can access the pulp chamber. Now in the next step, that is the fifth step, we remove any gutta percha of root canal filling that extends into the pulp chamber. So any filling in this zone is removed, and it is removed with a hot Wickman #1 instrument, and it is removed till the level of the alveolar crest. So if we have the alveolar crest here, till the level of the alveolar crest, GP filling is removed. So in this diagram we can see here the level till which the gutta percha filling has to be removed, and this total pulp chamber is opened up, access cavity is established, and the pulp cavity is made clear of all the gutta percha. Now any residual debris or stains in the pulp horns need to be removed, because if we leave behind any debris, there wouldn't be any contact of the bleaching agent with the dentinal tubules here, which are containing the stain, and it will result in ineffective procedure. So that is why removal of any residual debris from the pulp horn is one of the very important steps in the walking bleach. Now as we have already seen the removal of gutta percha at the till the level of the alveolar crest, and the second landmark that we have to consider while we are removing the gutta percha filling is the gingival margin. So we have to make sure that gutta percha is removed 1 till 1 mm below the gingival margin. So this particular area in relation to the gingival margin is cleared of the gutta percha filling. After that, the protective barrier is used so that these gutta percha which is left behind, so I'll just draw in blue, this is the remaining gutta percha filling, and in yellow we have the empty zone wherein we'll be placing our walking bleach. But if we place our walking bleach directly in this zone, these caustic agents, the H2O2 sodium perborate, will infiltrate through the gutta percha and through the spaces around it, and it will reach the periapex, and it may result in inflammation of the periodontal ligament. We do not want this to happen, so we have to place a barrier that will prevent the percolation of the bleaching agents into the gutta percha. So this is the next step after we have cleared the cavity of the gutta percha, the use of protective barriers. So seal the orifice of the root canal with at least 1 mm cavity over the gutta percha. This is to prevent the percolation of the bleaching agent into the apical area. The second reason why we need a barrier, especially in the cervical area, is if there is no barrier placed, this is the area which has a tendency to leach out the bleaching agents, and there has been noticed the side effect as external root resorption, the cervical resorption. So cervical resorption is one of the very important complication of walking bleach. To prevent that, we have to have a barrier which is extending especially along the shape of the CEJ. So we have to place the barrier so that there is no leaching of the agent into the PDL or in the cervical area. Now our tooth is prepared, a barrier is placed. So herein we have our barrier. Below we have our remaining gutta percha filling. Now this cavity, herein the smear layer is removed by using 25% solution of citric acid or 30% solution of orthophosphoric acid, and this area is flushed with sodium hypochlorite and water to remove any acid or any remaining debris. And this smear layer can also be removed by using EDTA or sodium hypochlorite. So whatever be the methods used, basically the purpose is to remove the smear layer. After the removal of the smear layer, then we desiccate the dentine by flushing the pulp chamber with 95% alcohol and drying it with air. Following the desiccation of dentine, we have to protect the exposed area of the patient's face. Then we prepare a walking bleach mixture wherein we mix the sodium perborate powder with superoxole, and we prepare a thick paste in a clean dampened dish, and then we carry this paste to the pulp chamber. After we have placed the paste of sodium perborate powder with superoxole, that is our walking bleach, into the pulp chamber, we place a small cotton pellet that is slightly moistened with the superoxole over this bleaching paste. So we have our access cavity, and herein we have placed our walking bleach, and on the top of the walking bleach we keep a small cotton pellet that is moistened with H2O2, that is superoxole, 30% superoxole, and then we seal the cavity. So these are the basic steps in the placement of the walking bleach. And we recall the patient after 3 to 7 days, but the maximum bleaching effect that we can expect is attained within rather first 24 hours of treatment, and this particular point is important. So after recall, that is after 3 to 7 days, we evaluate the results, and if the patient requires a second sitting, the second treatment procedure, the same steps are repeated again, and this repetition is done approximately 1 week apart. So in many cases even the single treatment is sufficient, but in most of the cases it requires 2 treatments. So that was about the walking bleach, that is a non-vital bleaching technique. Then we talk about the vital bleaching technique, wherein the tooth is vital and we are bleaching the tooth. So herein the agents are used from the external surface of the tooth. The solution which we use for the vital bleaching, especially in the cases of endemic fluorosis, is a solution wherein we have 1 part of anesthetic ether, 5 parts of hydrochloric acid, that is 36%, 5 parts of hydrogen peroxide, 30%. So this is a combination of vital bleach used, and let's talk about what role each ingredient plays. So the anesthetic ether, which we used 1 part, the basic function is to remove the surface debris. After the removal of surface debris, the hydrochloric acid takes care of etching the enamel surface, and then hydrogen peroxide is the actual bleaching agent that releases the oxygen to bleach the tooth. So this is the vital bleaching technique. So this is the normal vital bleaching technique. Further, we can use the heat or light application to enhance the process of bleaching, which is kind of used as catalyst. So application of 30 to 35% hydrogen peroxide and heat, or a combination of heat and light or ultraviolet rays, can be used for bleaching, and this is called as thermo or photo bleaching. Other than using heat or light for the activation of bleaching, even lasers have been used in activation of the bleaching agent. Commonly 2 types of lasers can be employed. So the purpose is we use the special catalysts that target the lasers in the area of stains, so that they rapidly decompose hydrogen peroxide to oxygen and water. Because of this, the speed of bleaching process is increased, and the lasers which we can use for this process is the argon laser that emits the blue light, and it doesn't heat the pulp. So without overheating the pulp, we can use argon laser. It is easy to use. It is best to remove the initial dark stains, but the problem is, as the stains become lighter, the effect of the argon laser, it lessens. So the laser becomes less effective as the stains get lighter. Then we have the second laser that we can use, that is the carbon dioxide laser. Carbon dioxide laser emits the laser light in the range of infrared light, that is the invisible light. It interacts directly with the catalyst peroxide combination, and it removes the stain regardless whether the tooth color is dark or light. So the disadvantage that we had with argon laser, that it only removed the dark stain, we did not have the same disadvantage with carbon dioxide laser. So these are the 2 lasers which can be employed in the laser induced bleaching. We have a technique of mouthguard bleaching, wherein the bleaching agent can be prescribed to the patient and patient can use it at home. And there are numerous products available containing either 1.5 to 10% of hydrogen peroxide or 10 to 15% of carbamide peroxide, but that degrades slowly to release the hydrogen peroxide. So this is a method of mouthguard bleaching, and it can be used at home by the patient. So that summarizes the basic bleaching techniques, including the non-vital bleaching, the vital bleaching, and the mouthguard bleaching. The points which are important as MCQ perspective are the percentages which we use, the combination, the active products, the barrier information, the complication of the bleaching, and the conditions which could be bleached out and not bleached out, etc. So with this, we end this session. Thank you.